When undertaking a remote assessment, whether that's telephone consultation or video consultation, prior to starting work, it is important to consider your environment. For most call centres and primary care centres, this will already have been predefined, and you will not need to make any adjustments. With the rollout of video consultation through Attend Anywhere, you may, however, need to consider the background, whether that is at home or in work, as distractions in the background will be visible to the patient or caller. You need to ensure you are working alone, in private, away from the family and pets, so there are no distractions which may be heard or seen. You may also be consulting for patients outside your normal area, and if you are, it is important to understand where the primary care centres are located for that area and how to give the patient directions to the unit, both geographically and then once on site. So you would need to know which outpatient department it is, how to give directions to the hospital, and then from the car park in the hospital grounds to the department. Developing a rapport with the patient or caller is clearly critical for the patient to have confidence in the care being provided by both yourself and the organisation. To help do this, we need to have what we call the remote handshake for remote assessments. We urge you to introduce your organisation and yourself by name. At that point, I usually then check that the patient or caller has heard me clearly, and if there is a poor line, I will phone back. Check the patient's demographics, both personal data and locations, and taking additional care if there are multiple callers in the same household, as it is easy to open up the records in the wrong order. I also personally apologise for any duplication and ask their story so far. I think particularly during COVID, there may have been additional delays in the system, and the patient's condition may have changed significantly for the better or worse since the time of the original call. So this isn't actually really duplication, it is updating the record situation in a timely manner.
In undertaking a telephone triage, you are rapidly assessing that the patient requires a further face-to-face assessment to adequately assess the patient. This may be at a primary care centre, a home visit, or by involving other teams, e.g. secondary care referrals, A&E or district nursing. The decision that a face-to-face assessment is required is usually made within the first few minutes of the telephone call, and further questioning should then be aimed at prioritising the urgency of the assessment and possibly the place of assessment regarding the severity of the illness and the need for secondary care referrals. If you are arranging face-to-face assessment, you do not need to undertake a full telephone consultation, as this could be duplicated further down the line. A telephone consultation takes place when you have assessed a patient as not necessarily requiring a face-to-face assessment, and you are aiming to finish the call with self-care advice with or without a further prescription. Consequently, you have to take a more detailed history, including past medical history, drug history, allergies, possibly social history. You also then need to agree a working diagnosis and management plan, arrange a prescription and the collection of a prescription if being faxed or collected from the PCC, and also you then have to provide adequate safety netting and follow-up advice if ongoing care is likely to be required all this takes considerably longer and is actually just added to the initial telephone triage part of the call. It is therefore inappropriate to compare the two processes in terms of performance management of clinicians. The performance management of clinicians must not be taken purely on the duration of the phone call. There is no point in criticizing someone with a long triage telephone consultation call length if they are completing a majority of their calls with telephone advice. Equally, if clinicians have a high face-to-face referral output, they should be encouraged to have short telephone triage consultation lengths appropriate for the outcome.
When you have made a decision that a patient needs assessment at home, there are several key things which also need to be covered. Clearly, the most important is to check the demographics and that you are sending the home visiting clinician to the correct address, not just the registered address. Identify if there are any particular access issues, particularly key safes, and many elderly patients will leave their back door open and they will ask clinicians to attend and let themselves in. This needs to be documented clearly in the notes. If there consider health and safety issues and inquire if there are pets. If there are pets, you will need to advise the callers or the patient that the pet will need to be put away, and I normally write a brief note in the case record that for the home visiting clinician to phone on arrival to ask them to put the pet away, because there may have been a long time since the original decision to carry out the home visit and the clinician's arrival. You need to prioritise the call carefully. Most patients in hours would wait 4 to 6 hours to be seen, so we feel a similar approach out of hours is fair and equitable. Urgent visits for terminally ill and palliative care are often required for symptom control and or adjusting syringe drivers in a timely fashion so that they only need to be replaced once per day. If the emergency 1 hour home visit has always been contentious within the out of hours service, there are challenges in arranging an assessment within an hour. However, we do feel that patients who are palliative care, severely distressed with pain or other symptoms, should receive treatment promptly. Very, very rare occasions where patients are actively trying to harm themselves or others rather than just voicing ideation would need a rapid assessment, usually by the police, who are obviously trained to assess these situations and restrain as necessary, but with ambulance and GP out of hours backup. This again is contentious, but I've always argued, and over 2 decades needed it once or twice. The support is as much for the other emergency service colleagues as for the patient, because if a patient has seriously harmed themselves or others or actually killed themselves, it is a very distressing situation for the health professionals. Just like we request support from the police to help us with potentially difficult situations, it is only fair that we should offer our support to other emergency services in these rare and difficult situations. Speaking directly with the patients, particularly adults, is a key principle for all consultations. I personally, however, feel that it is not necessary in all situations. If we are arranging a face-to-face assessment, we trust other adults to give information for adults who lack capacity, carers in residential homes, and adults for children, and we find that their history usually reliable. Two exceptions I definitely make are patients who are complaining of pain, particularly abdominal pain, and patients who are complaining of shortness of breath or difficulty breathing. I always try to speak to these patients directly prior to arranging a home visit, as it occasionally alters the urgency, both up and down. The caller may be saying they are seriously short of breath and they are clearly talking sentences. Equally, I've had one lady as a multiple call whose child had a upper respiratory tract infection on speaking to the husband, and I was going to arrange a home visit, a primary care appointment. The mother came on the phone also complaining of upper respiratory tract infections, but she clearly had stridor on the phone, and the 999 ambulance was arranged.